So all of the peptides, all the peptides that we use came out of rearranging the 191 amino acids that make up growth hormone, the growth hormone peptide. When I explain it to my patients what it is, the explanation that I use is that I liken it to a box of Legos. Those of you who have young children or like to play, you go and buy a box of Legos, and on the front of the box it will have a car or a windmill or something. And if you put the pieces together exactly, in however long it takes, you will have whatever is on the front of the box. So I tell the patients we have 191 pieces. If we put them together in perfect order, following the directions, what we get is what we call it in our office the holy grail of anti-aging medicine. It's for strength, energy, sense of well-being, mental clarity, and then growth hormone has amazing properties that deal with all sorts of psychological and psychiatric conditions, specifically paranoia, obsessive compulsive disorders, dark moods, suicide ideation, and then on a lighter side, not being able to start projects, not being able to finish projects, not being able to switch gears, and not being able to do two things at once. And again, when I explain it to my patients, I tell them that I was an ER doctor for 10 years earlier in my career. And we're in here talking about, our hormone. Most of those who don't know me, I'm kind of the hormone guy. We're talking about hormone balancing. And suppose my secretary comes knocking on the door and says somebody got hit by a car in the parking lot, and now I have to put away my hormone hat and put on my emergency room hat again. And can I do that? Can I switch that? And if you ask these questions, you'll find that these patients will say, "Yeah, that sounds like me. Yes, that sounds like me." And these so the growth hormone is a fabulous vehicle for, sort of to break through that. A lot of the patients will say, "Well, it sounds like ADHD," and it does. The issues are the medical issues are growth hormone is extremely easy to become accommodated to. And and now with the sports leagues and the politicians and whatnot, it's got the reputation of heroin, which of course it's not, and it also is extremely expensive. The nice thing about peptides are some of them are over the counter, some of them are some of them are injectables. There are spray forms, there are pill forms now, and the cost has come way down. And they're pretty well affordable. They're still even in the supplement world somewhat expensive, but in the growth hormone world they're extremely affordable. I put in the chat. I just got just at 1 o'clock this afternoon from a company called Nootropin. I have no financial backing interest in them at all, other than I'm a customer. That they have the Thymolphysin peptides, and I gave you their address and phone number and an email address. So I was going to start this talk because we're going to focus on the immune peptides by stating that this is all well and good, but we can't get it. Well, apparently we can now. So usually hormones or peptides 101, we start with what is a peptide, and so we're all on the same page. This is a molecule of a peptide, and we're going to talk about this one because this is an interesting one. This is also an immune peptide. We're going to get to this in a few minutes. But what are peptides? What are proteins? What are amino acids? So amino acids are groups of organic molecules composed of an amino group, an acidic carboxyl group, and an organic side chain. And the structure is right here in the corner. And this is what makes each one separate, different. There are essential amino acids. These are the exogenous ones to the body. They have to be taken in some sort of form: food, liquid, intravenous, transdermal. There are 9 essential amino acids. Histidine becomes histamine. methionine, tryptophan. You're all familiar with some of these names. Phenylalanine. Non-essential amino acids are internally generated, and there are these 9. And in conditional ones that they're not essential except in times of stress. And as you can see here, this is our again nitrous oxide components, arginine. We have glycine, which is one of our components for glutathione, which is one of our chief antioxidants, and glutamine. Proteins are 2 or more amino acids that are linked by a peptide bond. Protein chains are usually more than 50 amino acid combinations, and they enable growth, repair, and energy sources. And they give cells body and shape. Lastly, peptides are less than 50 amino acid chains. So proteins are greater than 50 amino acid chains. Peptides are less than 50 amino acid chains. Oligopeptides are described as less than 20. Polypeptides is 21 to 50 amino acids. And the sequence shape and type of amino acids involved determine the peptide's function. So I just go through this just so we know that we're all on the same page and what we're talking about. And this is kind of a schematic. We have random amino acids. They become linked together as peptides. Greater than 50 amino acid chains are proteins. Dr. Halasa, if you're there, if we could mute who's ever in the background. I don't have little kids with me, so it's not me.
You're good. They're muted.
We're good? Okay. So there are over 7,000 peptide sequences noted. There's 500 of some sort of therapeutic value, and there's 60 approved FDA medications. I originally did this lecture in 2019, and there are 3 new ones that have come out just in the last 12 months. So there's actually 63 now. Where I come from, AGE is a 4-letter word, and the sort of the model for peptides is skin repair peptides. If those of you deal with any type of aesthetics or skin issues, know that skin products are very, very prominent in every culture. We have what I call built-in senescence. After age 26 or 27, that's our peak, and then things start to go downhill after that. Collagen breaks down. At first, we don't really notice it as much, and I describe it as like a little pinhole in your fuel line. Sooner or later, the fuel starts to leak out just a little bit, and kind of shrug it off at the beginning. But after about 10 years, we start to notice things are a little bit different, and we start to notice there's little spots and wrinkles that weren't there. And then in 10 more years, we have probably a decrease in collagen by about 20% from our peak at 26, 27, and the damaged collagen layers sort of cry out for more collagen. The peptides that we use are sort of the messengers, and we try to regenerate the tissue. Internally, we have a damaged system, and so it's basically a disability of the integument or the integumentary system. There are whole industries of peptides, specifically polypeptides in skincare. The skin kind of misremembers its repair sequence, and it accelerates the restoration of new collagen, but not in the form that we want. So the skincare products are designed to restore our elasticity and strength in our skin to a younger or more youthful appearance. One of our hats here is we do a lot of aesthetic treatments, and we like PDO threads. These are smooth or lifting threads that we place under the skin, and it gives us a non-surgical facelift. And we get an immediate lift from the barb threads, picture fishing line that we thread under the skin. Dr. Halas, I got a whole another unit for you and to teach. And you know, the skin, the threads catch in the undersurface. It's in the subdermal layer, and we get an immediate lift. But that's not the end of it. The threads themselves act as micro irritants, and we get new collagen formation around the threads, and we get a thickening and smoothing of the skin, and we get quite a nice look to that. It takes about 6 months to get the final look that we're going to get when we do a thread lift, and we get a
So do
smoothing.
you have a company who's doing the thread lifts? Because it's part of my second part.
Well, I have a company that's doing the thread lift. I'm the company that does the thread lift.
You're the company with doing the thread. Okay, great.
I can teach you how to do thread lifts. It's not a problem.
It's part of we're doing fat transfer, but also we're going to do thread lifts as well.
Well, we do, and I'm sorry, I'm a little bit off topic. So we do, you know, I do what we call a non-surgical facelift. So we use neuromodulators. Am I allowed to use brand names, Dr. Olasa? Is that okay? Or
that's fine. Just go ahead. This is
okay. So you know, we use Botox and Xeomin, you know, for wrinkles, usually above the forehead, in the forehead and above the eyes. In the mid face, we'll use dermal fillers. And there's a number of different types of varieties. And then to get a nice lift, we'll use our PDO threads. To polish it all off, to finish it all off, we'll do our platelet-rich fibrin, and we'll either inject it or we'll do a dermabrasion. We do have an electronic dermapen that we'll use, and we'll use that as sort of our polish to finish the skin off. And we get quite a nice look. We get about a 15 to 20 year decrease in or reversion in the look. I'm sorry, I didn't know I was going to go off on that tangent, or I would have brought this up.
That's our program. We're adding fat transfer, me and Dr. Joseph. So if you want to be engaged, involved in doing the facelift, we have no problem. We are looking for more, you know, doctors to be engaged, but that will be another fellowship program where we are creating.
That's another program. So we actually have we actually have a little school here at my office. We have a few students, and we've taught the Botox 101, 102. Here's a pitch: 101, 102, 103. Dermal fillers 101, 102, 103, PDO thread lifts, smooth and barbed, platelet-rich fibrin, and we also have some. We now have a radio frequency non-invasive technique also we use. Okay, back to the peptides. Peptides. The first peptide was insulin. Peptides are tissue specific rather than globally specific, which are hormones. They are mitochondrial messengers, and they are intimately involved in the inflammatory process. When one ages, on the left-hand side, we get an increase in cellular cortisol, a decrease in growth hormone and IGF-1, sarcopenia, decreased insulin sensitivity, decreased cognitive function, decreased immune function, decreased steroid production, and a decrease in mitochondrial biogenesis. The peptides are anti all of those things. They enhance the immune system. They improve sleep, memory. We have peptides for depression, anxiety, improved cognition, especially after traumatic brain injury. Antimicrobial, antiviral, antifungal, cellular rejuvenation and restoration, and pain relief. When we started using these about 10 years ago, there were about 4 of them that were reliably compounded. There are probably about 90 to 100 at the moment, and I actually have a hard time keeping up with them. And those of you know that, well, you may or may not know that in the original, the 2 coronavirus outbreaks in 2005, and I think it was 2011, 2012 in the Middle East, Thymosa alpha-1, one of the peptides we're going to discuss, were used quite extensively and quite successfully to decrease the inflammatory response to those coronaviruses. So this is just kind of a schematic of what I just talked about. And here's a classification of the favorite peptides. So the growth hormone mimetics, we're going to use the growth hormone releasing hormone and growth hormone releasing peptide. So those are two separate uh, uh, pathways that that tell the hypothalamus to release growth hormone releasing hormone and to generate growth hormone. Semarelin was FDA approved in 1991. It is the first 29 amino acids in the 191 amino acid growth hormone molecule. The end result is that the peptides stimulate your body to produce that which we're injecting. So semarelin will stimulate your body to produce the first 29 amino acids, 1 to 29. The end result is an increase in strength, energy, and sense of well-being, and mental clarity, which is actually pretty good. It's about 80% of what we're looking for in a growth hormone treatment. It was at much less cost, and the big advantage is that it does not come in like the blob. It does not cause accommodation. If you stop using it, it wears off in approximately 2 to 4 days, and you're back to where you were. The issue, the medical issue, of course, with growth hormone is that it comes in like the blob and shuts everything down, and sometimes it doesn't come back. CJC 1295, and you're going to see a lot of numbers here. So it's 1 to 29.5 with or without DAC as drug affinity complex. And what that is, this is a synthetic semarelin, somewhat refined, and with the DAC drug affinity complex, it changes the half-life of the molecule from about 6 hours to 6 days. And so this becomes a once a week injectable. And so we've been using this one for a long time in our office. We get our retail charge on this is about $40 for a 0.5 cc injection. The patients get approximately a 60 to 70% increase in IGF-1 within 4 weeks, and it will stay for at least 4 weeks after if we stop the treatment. We usually do 4 to 6 weeks on, and we do 2 weeks off as a cycle, because you can get some accommodation to it. And we call it, around our office, and I know Joel's on here, we call it the Holy Grail, because we were looking for something that, we could attract patients to come to the office. And as you know, when they come to the office, they like other services. So we've really found this one as a practice builder is really a great tool. You can get it without the drug affinity complex. That makes it a 6-hour half-life, so it's a daily shot. And we instruct the patients on how to inject it. And these are insulin-like shots. It's usually for daily use about 0.2 cc's. We'll do it 6 days on, 1 day off, or and sometimes the patients don't want to do it that way. We'll do it for 7 weeks on, 1 week off. You can build antibodies. You don't want to use these things continuously. Growth hormone releasing peptide actually acts on the ghrelin pathway, and these were growth hormone releasing peptides 2 and 6 were the original ones. So if you use the growth hormone releasing hormone and growth hormone releasing peptide together, they'll come in as a solution. They're synergistic, and we'll get a 1 + 1 = 7 or 8 fold increase in IGF-1 rather than using one or the other. The problem with either 2 or 6 is that growth hormone releasing peptide 2 acts on the upper stomach, and you can get some GI distress, some GERD or nausea. And growth hormone releasing peptide 6 greatly increases ghrelin, and it causes quite an appetite. So for the bottom two were available. We told the patients, well, name your poison. Do you want to be nauseous or do you want to be hungry? 6 usually won out. The newer ones are ipamorelin and hexamorelin. Hexamorelin is actually an FDA approved for abdominal lipodystrophy in AIDS patients. But there's no reason that it shouldn't work in non-AIDS patients. That's what it's actually indicated. The immune modulating peptides are thymosa alpha 1, which increases Th1, and thymosa beta 4, which increases Th1 and also will decrease Th2.
I think it's a typo there. Thymosin beta and BPC both goes increase in Th2 and decrease in Th1. Thymosin alpha increase in Th1. So
yeah,
there's
okay.
a typo there.
All right, sorry about that.
BPC
BPC 157, and I'm going to talk about that one because it's really kind of a unique molecule, and it's kind of a fun one to learn about the history of it. This one decreases Th2. It can be given it's good for wound healing. It can be given sub-Q. It can be given into joints for tendon issues. It can be given as an eye drop, a nasal drop, or orally for GI issues. For pain, we have the BPC 157, thymosa beta 4, epithalon, and the growth hormone combination. Brain peptides, and these are all separate lectures that we give for memory, depression, anxiety, traumatic brain injury. These are just what they are. I'm not going to go into specifics on them. If you like what you hear, we can do. I have about 7 different lectures on peptides, cerebrolysin, Cmax, and Salank. The last 2 are actually come from Russia. They are get them as nasal sprays. Sleep peptides are epithalon and delta sleep inducing peptide, and AOD, and the antimicrobial peptide is LL37. Dr. Falasa kind of sprung this lecture on me. There are many more that I've not covered here, but those are the big ones. Those are the ones that we like, and those are the ones that I'm very comfortable with. Peptides, think of them as a fine-tuning mechanism. They fine-tune your hormones of your immune system, inflammatory cytokines, cancer cell destruction, libido, sexual arousal, weight loss, wound healing, brain function, urinary and reproductive system. In the last year and a half, PT141 has been approved as an FDA-approved drug called Vyleesi for premenopausal female sexual dysmorphia. Actually, we've been using it in males for many years, and so we would get it from a compounder. It would usually cost in the range of about $50 to $100 for a bottle that would last anywhere from 1 to 3 months, and now it's $899 for a month's worth. But they'll give you all sorts of coupons and whatnot. So FDA approved, but at a price. So I'm going to start with BPC 157. I really like this one. We use this a lot for wound healing. It was originally described by Pavlov, of all people. And if you like my little cartoon there, watch, I can make Pavlov do it. As soon as I drool, he smiles and writes something in his little book. So kind of turn things around. He had isolated pure gastric juice from surgically prepared dogs, and this he calmed the gastrointestinal system. And he was famous for treating GI issues with from dyspepsia to gastritis, diarrhea, constipation. It stimulates red blood cell production, and it actually has a antacid type characteristic to it. It took 12 years after his death to determine that what he had put together was this this peptide BPC 157, and it also after that he was it was found to help relieve B12 and folic acid deficiency. So the mechanism of action, it accelerates bone healing, it protects the GI tract, it promotes wound healing. We use it in joints, especially joints that are non-healing, non-surgical failures in fractures. and we use it a lot in the tendonitis and post-op. We use it a lot. It speeds up healing, repair, and regeneration of cartilage and muscle. We usually use it in the office. If the patients live close by, we'll do 3 shots a week. I'll give you the dose in a minute. Or we'll teach them how to do it to themselves. Again, it's only about 0.2 to 0.3 cc's. It stimulates new vascular formation, nitrous oxide production, angiogenic cytokines, VEGF, FGF, and TGF beta. It upregulates anti-inflammatory gene transcription factors. It downregulates tumor necrosis factor. It influences corneal restoration. There's neuroregeneration, especially from traumatic brain injury, and it upregulates growth hormone receptors. It does come in an oral form, and you can get it, as I said, as an injectable. It will decrease leukotriene D4. It mediates lipids, and it acts as a vasoconstrictor, and it improves myeloperoxidase. Will help with muscle tissue response, and it will help with organs that are vascular. It does not help with organs that are not vascular. Okay. It improves insulin derived growth factor, platelet derived growth factor, fibroblast growth factor, and growth HGH itself. You need some intact tissue, so we need some sort of proof that we have intact tissue. A complete tear of, say, of an MCL or a rotator cuff, if we inject our EPC 157, we're not going to get anywhere. So it increases fiber matrix repair, and it helps recover a ligament tissue. It becomes thicker and sturdier than before. So one of the things that we've done here is we've been teaching all of our practitioners. We got a very inexpensive that you can plug into your phone ultrasound devices for less than $3,000. It comes with a lesson on how to learn how to use it. And so we do all of our injections with needle guided ultrasound, and we make sure that that we have some intact tissue. We're doing quote unquote weird things to begin with. We don't want to. We want to ensure that we're going to get some positive benefit. Corticosteroids long-term block nitrous oxide collagen synthesis, and you get atrophy of the treated tissues and muscles and tendons. EPC also blocks the long-term effect of the corticosteroids, and it protects the endothelium and formation of scar tissue. So we can use corticosteroids with EPC 157 and eliminate a lot of the long-term negative effects. It's best used that we use it in the GI tract. We use it for all sorts of stomach ulcers, GERD, lower intestinal inflammatory issues. It comes in a pill form. It's relatively inexpensive. It revives and repairs and rejuvenates the GI tract, and it provides considerably more healing than H2 blockers, proton pump inhibitors, and gastric coating agents. It's useful in inflammatory bowel disease, ulcerative colitis, leaky gut syndrome, diverticulitis, gastric reflux disease, pretty much anything GI. It prevents and reverses mitochondrial damage. It reverses the inflammatory aspects of rheumatoid arthritis, inflammatory aspects of lupus and Hashimoto's, and it heals wounds in the corneal epithelium. It does come as an eye drop. It will increase serotonin to a degree be equal to or better than SSRIs. And I can get you I think at the end of each segment, I have the references. And it's effective against both an acute and chronic anxiety. It improves heart failure. It eliminates hyperkalemia. It stabilizes both high and low blood pressure. It prevents and reverses arrhythmias. It reduces and reverses urinary stress incontinence. It's cytoprotective against NSAID administration. It prevents hepatic encephalopathy, interacts with dopamine, serotonin, opioids, and GABA neurotransmitters, and prevents glutathione depletion. It mitigates neuronal damage and improves early outcomes and delays mortality in the first 24 hours post traumatic brain injury. It attenuates behavioral agitation, muscle twitches, edema, atrophic muscles, and enhances growth hormone. It outperforms acyclovir in the treatment of herpes infections, and it normalizes esophageal and pyloric sphincter. In multiple sclerosis, it can help decrease nerve damage in the corpus callosum and the anterior horn of the motor neurons. Wound healing in alkaline burns. It improves wound healing, and cordial abrasions will respond, and there's the dose there. You can have that compounded. Safety, there is no lethal dose to kill 1% of the population that could be found. And by contrast, the lethal dose, 50 of some of the substances here, 6 liters of water, 118 cups of coffee, 175 shots of espresso, or 13 shots of 40 proof alcohol, all have a LD factor of 50. We have an LD factor that could not be found, so it's extremely safe. I'm not going to read these. These are some of the areas that have been used and had some successful improvement with our BPC 157. Here's the dosing. Orally, 500 microgram Trochea capsule once a day for GERD, and for injectable, 800 to 1,000 micrograms sub-Q twice a day for 4 to 7 days for an acute injury. 1 to 2 cc's. Mix it. You can mix it with platelet-rich plasma or fibrin, or 0.515. We actually use 0.2 now daily for sub-Q or into the joint itself. And it can be given IV with 5 cc's normal saline as a push. Here are the references, and we'll get you the slides. I'll put them up on our website, and Dr. Halassa, if you want them, I'll make sure that you get them also. Okay, so here's Dr. Halassa's favorite, Thymosa Alpha 1. And it has indications in 40 countries. It's approved by their whatever FDA is in 40 countries in Europe and the Middle East for hepatitis B and C, HIV/AIDS, non-small cell lung cancer, hepatocellular cancer, malignant melanoma, and chemotherapy adjunct. It reduces hematological side effects from 5-fluorouracil and cyclophosphamide, isocyanide. It improves chronic inflammatory conditions, including autoimmunity, cystic fibrosis, Lyme disease, anything that requires an immune response, steroid-induced apoptosis of the thymocytes. It increases the depressed response to vaccinations. It's an adjunct to flu vaccine. Geriatric immune support, DeGeorge syndrome, sepsis, and it helps prevent the flu.
You're missing allergy, asthma.
I'm getting to it. So we have that there. We had that there. Okay, allergy and asthma. Sorry, I forgot it. Left it out. It has a dual mode of action. It has an antiviral. It increases MHC1, and it increases the production of interleukins 1, beta, interferon gamma, interleukin 2, 3, 6, and 10. Also interleukin 4, I left that off. Remember, interleukins 4 and 10 are anti-inflammatory for the most part, cytokines. It also improves CD3, 4, and 8, and has antioxidant activity by specifically improving intracellular glutathione. It prolongs mean life by approximately 28% in some experiments, and it exhibited a 2.8-fold decrease in all cancers. Non-resectable, non-small cell carcinoma of the lung demonstrated a significant improvement in relapse-free survival when Thymosa alpha 1 was administered for up to a year. Overall survival rate correlated with T cell restoration to pre-treatment levels. A couple of quirks here. Women seem to have a significantly lower intrinsic Thymosa alpha 1 than men. Autoimmune patients also have lower Thymosa alpha 1 levels. Patients on disease-modifying anti-rheumatic drugs have higher Thymosa alpha 1 levels than autoimmune patients that are not on DMARDs. Thymosa alpha 1 levels are significantly lower in patients with severe infections and cancer. Side effects are pretty minimal: restlessness and pain, redness and pain at the injection site, generalized edema, transient muscle atrophy, polyarthralgia, and rash, a transient increase in ALT up to twice baseline, and current recommendations including continuing therapy unless there are frank signs of liver failure. We've been using this for approximately 10 years. I can say that other than a little bit of soreness in the injection site, we really don't see any of these. I'm not in the real world. There is a brand name called Thymolphysin, or that's the generic name, Xidaxin, which is a proprietary Thymosa alpha 1 product. It's made by the Cyclone Pharmaceutical Company in Shanghai, and it is approved in 30 countries for the treatment of hepatitis B and C, and is a cancer chemotherapy adjunct. The dose is 1.6 milligrams, injected sub-Q twice weekly for 6 to 12 months, and it's adjusted to a little bit lower for younger patients, less than 40 kilograms. The dose for the indications that we use, and we use it mostly for autoimmune and immune issues. 1.5 milligrams sub-Q every third day. We use it for viral infection for 2 weeks. HIV and complicated immune issues, we'll use it for 3 months on, 3 months off. It has a 2-hour half-life. So, I alluded to the coronaviruses seem to be susceptible to Thymosa alpha 1, at least the older ones, the 2005 outbreak and the MERS outbreak, which I believe was in 2000 and 2011, sometime around then. And genes associated with the cytokine signaling and production were upregulated in blood cells from patients with COVID-19. They had overexpressions of interleukin-6, TNF-alpha, interleukin-1 beta, interleukin-10, and chemokines CCL2 or MCP1 and CXCL6. And Thymosa alpha 1 basically downregulates all of those. There's your references there. There was one paper that I found that stated there was no significant association between using Thymosa alpha 1 treatment and increased or decreased mortality associated with COVID. There was that one. There were 3 papers that asserted that patients in the Thymosa alpha 1 arm of their studies had a longer survival and better survival rates. Here again are the references for everything we just talked about. And lastly, we'll talk a little bit about Thymosa beta 4. Thymosa beta 4 actually works on muscles, and muscles contract and relax by sliding of one protein, myosin, over protein actin in a series of repetitive events. Myosin is a thick motor protein, and actin is the thinner scaffold. Thymosa beta 4 it upregulates actin and is responsible for muscle contraction. It stimulates the formation of healing cells. It improves cell migration to a site of injury. It is anti-inflammatory, antiviral, cardio, and neuroprotective. Useful in acute situations such as the flu, upper respiratory infections, and it's been used in the Ebola and Zika virus outbreaks. And in chronic diseases, it's been used for HIV, Lyme disease, malaria, and also for Herxheimer reactions. It's Pseudomonas aeruginosa in the eye is quite susceptible to a combination of Thymosa beta 4 and Cipro in an eye drop form. Useful for recovery of in myocardial infarction, remyelinating nerve tissue damage from peripheral neuropathy or multiple sclerosis, hepatoprotective in alcohol and LPS liver injuries. It prevents alcohol and LPS-mediated increases in liver enzymes. It decreases reactive oxidative stress and lipid peroxidation. It increases antioxidant activity. It improves glutathione use. It improves manganese use. And it prevents the excess pro-inflammatory cytokine formation and liver fibrosis. It's useful in wound healing, angiogenesis. It's cytoprotective, and anti-fibrosis. It reduces cerebral infarct volume, cardiac infarct volume. It preserves cardiac function and improves cardiac wound repair. Soft tissue repair, tendons, ligaments, muscle, sport, and athletic injuries, stasis ulcers, brain issues, if autoimmunity is suspected, ischemic strokes, spinal cord injuries, traumatic brain injuries, concussions, MS, dry eye disorders. So I hope, while I would go through these and give you some of the reasons that to look at something, along these lines, you think about some of your patients, the ones who've been more difficult and maybe have had to go elsewhere and come back and they tell you that nothing's worked. Well, you'll find that we have something else in our toolbox, and we do get some results for some of these things. Sometimes it's quite miraculous. Corneal injuries. It's in phase 3 trials for epidermolysis bullosa, pulmonary fibrosis, non-alcoholic fatty liver, cardioprotective. It reduces mortality, reduces endotoxemia and sepsis. In multiple sclerosis, it will decrease demyelination. The T cell helps the T cells penetrate the blood-brain barrier. MS presents with it as an infectious etiology. Epstein-Barr explains the key members of multiple sclerosis. There's a 10 to 20-fold increase in incidence of multiple sclerosis in Epstein-Barr. And those of you who work in autoimmune issues know that the Hashimoto's is also triggered. Most likely, the first thing we look for is Epstein-Barr. We get improved functional outcomes, decreased in progression of demyelinization and neurological function. If we add the two together, the thymosin beta-4 targets multiple cells. It reduces axonal damage, apoptosis. It remyelinates and rewraps the axons. It's neuroprotective. It's anti-inflammatory. We add that with thymosin beta-1, and we get an anti-inflammatory antiviral response. It improves regulatory B cells, and it's pleiotropic. Doses here are thymosin beta-4, 3,000 micrograms per ml as a loading dose, and then 30 to 100 sub-Q daily. Treatment cycle is 3 months on, 1 month off, and you can use it concurrently with thymosin alpha-1 and BPC 157. But we come off of the protocol with, we do 3 months on of thymosin beta-4, then we switch to thymosin alpha-1. That way we do not build up the antibodies, and we'll intersperse the BPC 157 if it's indicated. And we like the oral form for autoimmune and demyelinating diseases. So if we put it all together, we get immunoregulation, thymosin alpha-1, neuro repair, thymosin beta-4, the GI leaky gut syndrome, BPC 157, and for the total systemic repair, we have your HGH and secretagogues. Here are your references. This is a chart that I put together with the different symptoms and which of the peptides is effective for as you can see there, pain, immunity. I'll get rid of this there. But you can see what the different symptoms. We have the doses here and the conditions that it treats. So I made it very, very simple for you. You don't have to go through the whole lecture. I did it myself. And here are some of the other peptides that we work on. PT141, that's our sexual dysfunction peptide. Growth hormone releasing peptide is our growth hormone mimetic. CMAX and Salank are nootropics. These are all separate programs. CJC and ipamorelin are the newer versions of the this one up here, growth hormone HGH mimetic. We are. I am the executive director of the American Osteopathic Society of Rheumatic Diseases. Those of you who know me, we've let our we have applied to change a charter that to become the American Osteopathic Society of Integrative Medicine, which I hope you will all support. And you don't have to be an osteopath. We will be in Phoenix, Arizona, October 22nd to 24th for OMED, which is one of the largest osteopathic physician scientific conventions that is held every year. It will be held this year. There are usually 3,000 to 5,000 physicians there. We started out as a small group. They gave us a room with last time we were there, they gave us a room with 60. We ended up with 600 out of the 3,000. And there's family practice and internal medicine there. So we are the go-to people. We also have a Tuesday night webinar, 8 p.m. Eastern, 5 p.m. Pacific. There's the link for it. I will send Dr. Olasa the slides so he can put it up on his website. I'll put this up on ours, which is aosrd.org. And did it all in an hour, Dr. Olasa. So there you go. Now, just so you know that we have lectures on just on growth hormone peptides, on the brain peptides, on the wound healing peptides, sleep peptides, pretty much anything that you're struggling with. We have peptide. We have some peptides that we can use. So, I see there's some chat questions.
So, Dr. Bill, it was an excellent lecture. Which peptide you use the most in your practice?
Well, up until the last 3 months, we were using Thymosa alpha 1. I didn't even mention hair growth. Thymosa alpha 1, Thymosa beta 4 were the ones that we were using the most. But now we've gone to the growth hormone ones, and I like I know it's a synthetic, but it's CJC 1295 with ipamorelin. So that's your 2 pathways, and that'll increase your IGF-1 level by anywhere from 50 to 80% in about 60 days. And
so you're using the CJC 1295 with DAC or without DAC?
Usually they make it with DAC. You have to actually ask them to not make it with DAC. So
are there any complications for the using with the DAC?
The DAC makes it a once a week treatment.
So the cost is not different, right?
They're a little bit more expensive, but not that much.
And what dose do you use for CJC 1295?
If we use the daily one, we'll use 0.2 cc's sub-Q at bedtime for 6 nights out of 7 during the week. We give them a Saturday or Sunday holiday. Some patients say they can't remember that; they just want to use it every night. So then what we'll do is we'll use it for 7 weeks on, 1 week off.
Doesn't it have some milligram or units or something? Because 0.2 ml, we don't know how many units or milligram that means.
Well, it depends on how it's diluted.
Right, exactly.
So if it's diluted with, if it comes as a powder and you dilute it with 2.5 mLs, 0.05 cc's is 2 units. So it would be times 4. So it would be 8 units.
So you use once a week. Okay. So that's how the 4 injections will do it. Okay. All right. What about, do you use the TA1 and TB4 together?
Um, Originally we did, and I know some practitioners do. I don't. I like to be able to stretch it out so that we get sort of a longer, a bigger bang for the buck. Maybe our results aren't as quick as if we use them together, but I like sort of sequencing them. This way I can tell what's working and where and why. Otherwise you really can't.
Because you had in your slide that 1, 2, and 3 using together, so combination therapy.
Right.
So with the TA1, TB4, and BPC 157.
Yeah, I mean, you can use them. It's pretty much on an individual basis. I don't have a hard and fast rule. And these things have evolved over time. And the last 6 months to a year, it's been difficult to even get these things. There is a company I can talk about, Integrative Peptides, I think it's called, that makes pill forms. I don't know the Thymosa beta 4 and TB4 and Thymosa alpha 1. They call them Thymosa alpha. They call them fragments. So they put out literature that's almost exact to what we see from our compounded formulas. But quite frankly, I don't know what they'll tell you it's comparable. I don't know.
Okay.
The FDA's sort of cracked down on Thymosa
Right.
alpha 1, Thymosa beta 4, and like I said in the chat, I put the Nootropic. I just got that email this afternoon that they have it. So I don't know how long they're going to have it.
So when-
Which pharmacy do you use for all these peptides?
Well, originally we used TaylorMade in Kentucky. Now, if you know what happened to TaylorMade, they kind of blew themselves up. There was something about about 3 years ago. We used them for the first 6 years that we were using them, and they were quite reliable, and everything came fine. And then things started to go wrong, and we kind of got wind. You can look it up for yourself. I don't want to cast aspersions, but it had something to do with horse racing and the FBI. And there's newspaper articles. Then we had to sort of go look elsewhere. So there's a company called Empower, EMPOWER. We use them. They're out of Houston. If you want the addresses or and contacts for any of these, just send me an email or a note, and I'll have my folks in the morning, send that to you. I did put in the Nootropin one. We do get a lot from Nootropin. They're out of Florida. Anazao will make a few of the peptides, but a lot of times these are hit or miss. So the question is, does Thompson beta, so that's Thymosa beta 4, help heal hernias? Any type of wound healing, it will be an aid. Never say cure, never say anything, but it can help. When you're talking to patients.
What are you doing, Karen?
So, and let's see.
To what?
We can never talking in the background. Maybe we can turn them off. Hear that? I guess that's okay now. Okay. My info in the chat. So, okay, there's Dr. Burgess. They wanted to know about sleep. So you can get me there, or you can get me 570-881-6821. You can get me at those places. And if you want to go through the AOA, AOSRD info at Gmail.
Dr. Bill?
Yes.
Great lecture. Thanks a lot. Who do you recommend for a study of this in terms of like anybody that puts out a manual or compendium that we can work with? That you
Okay,
like?
so Edward Lee and Louis Martinez, they're out of Orlando. They run something called the Clinical Peptides Society. So I've spent time with them. And then there's another outfit called the International Peptide Society, and they put out papers also. They get to be a little bit sticky for me, so they sometimes get a little bit pricey and whatnot. And I'm you know me, I'm kind of humble and down to earth. So
Nothing
but,
like
you know,
nothing like Amazon peptides for dummies or something, huh?
well, you can go to if you want. I actually wrote a whole series on peptides. But it was for a lay journal. It was for like a throwaway magazine that we have here in town. It's called. You can go to. It's called Healthy Beginnings Magazine. It's hbmag.com, and if you type my name in the search engine, they're not being published anymore. These were probably published in 2017 and 18. I have sort of the you know, non-medical, I'm standing in the supermarket line version of, and I talk about growth hormone, and I talk about the brain hormone, the brain peptides, and also these Thymosa alpha 1 and Thymosa beta 4, but I put it in lay terms.
So Dawn is no longer publishing that, huh?
You know, they were doing it online, and then I haven't heard anything for over a year. You know, it was here in Reno. It was one of those supermarket magazines. They put out 30,000 copies.
Yeah, I'm familiar with Dawn.
A week, and you know, I wrote for them for about 6 or 7 years, and there is a whole series on peptides in there. If you know, but again, it's kind of it's the non-medical version.
Great.
Of it. So, okay.
Yeah, great. Thanks a lot, Bill.
So I'm going to put this up on our website, which is it'll be aosrd.org/webinars. It'll probably take about 48 hours to get there, to get up there, and we'll have this lecture for you up there. If you want any more of these, we have about 8 of them. That's pretty complete and goes through every peptide and you know, indications and side effects, and we go through a lot of the you know, the immunological aspects of using them. So anybody, are there any other questions here?
Yeah, it would be good to have you as a series, lecture 1, 2, 3. So Dr. Halasa, and you can schedule that. That would be good, because we do need some more for the brain and sleep, and those are the common issues of inflammation, cognitive dysfunction, for TBI, although you mentioned about those. But what do you do when your T cells and B cells are dysregulated, and CD4 CD8 ratio either is high or low? How do you really work on that with the peptide?
Okay, well, the ones we just talked about. I usually start with TB4, Thymosa beta 4. I'll start with that, and we'll do our 6 days a week on, 1 day a week off for 4 weeks. Then I'll switch to Thymosa alpha 1 and do the same thing. And we'll do 6 months. So we'll do months 1, 3, and 5 Thymosa beta 4, and months 2, 4, and 6 Thymosa alpha 1. I might add, there seems to be a re-stimulation of hair growth and a decrease in hair loss with this combination also. That came as quite a shock at first.
Have you
seen? We actually use this as part of our hair restoration program. So.
Hi, Doug. Can you please tell if nutrition plays any role, particularly keto diet?
I'd be a fool if I said no. Yes, obviously it does. You know, white flour, white sugar, those are poisons. And the paleo diet, keto diets, those are the ones that we recommend, for our patients. I actually have a program that I got from actually one of Dr. Lavell's, if you know him, from A4M. He's got a terrific program. And again, I don't get any royalties. I have no, I pay into it monthly. I've had it for about 8 years, and it makes it very easy, especially if you're a solo practitioner and you don't have a nutritionist. You type in the patient's name, it'll send them recipes, menus, shopping lists, weekly shopping lists for you name the diet. They have it as keto diets, Mediterranean diets, paleo diets. You can write your own. I wrote my own for thyroid patients with thyroid issues, patients with low testosterone, patients with menopausal patients. I actually wrote my own using their platform, and it'll run anywhere from 28 days to 50 or 60 days, that one's a time saver.
So what is the mechanism, though? What is the mechanism
for
increase of peptides with this ketogenic diet? Do you have any specific mechanism?
Again, so what these peptides, the ones that we talked about tonight, specifically target interleukins 1B, interferon alpha, interleukins 2, 3, and 6, and national killer cells, and CD3, 4, and 8. So that's your mechanism. It becomes quite global at that point.
Okay. Let me get this clear about the mechanism here. I mean, Dr. Bell's presentation was excellent, over excellent. I like all the way that you are connecting the dots and explaining the details and the protocols and the dosage. But generally speaking, when we are trying to manage chronic diseases, we can classify them into degenerative diseases, autoimmune diseases, chronic infection, cancer, metabolic diseases. And we find out that an infection in general, especially the intracellular infections like virus or Lyme disease and cancer, along with allergies, those are diseases that you can manage with thymosin alpha. And why? Because in infection and cancer, you want to polarize the immune system to Th1, so you can have enough cytotoxic T cells, CD8, to kill those infection, especially intracellular infection and cancer. And then allergies, because allergies are Th2 dominant, so you want to shift them to Th1, so you use thymosin alpha. So those are 3 things covered, right? Intracellular infection, cancer, allergies, very clear, Th1, no question about it. When it comes into metabolic diseases and degenerative diseases, and autoimmune diseases, those are 3, and chronic inflammatory diseases. Autoimmune inflammatory diseases, most of them are Th1, few of them are Th2, so dominant. So that means most of the cases you're going to use the T beta, thymosin beta 4, and the BP 157. Those are shifts the whole thing into Th2 and Tregs, helps to decrease the inflammation. So that's what I would use. In degenerative diseases, I will also use thymosin beta and BP 157 because they shifted to Th2 Tregs. Metabolic disease, hypertension, diabetes. Is asking about, I will use thymosin beta, and also use the BP 157. And the reason BP 157 also has an extra, in addition to it helps as anti-inflammatory and wound healing, but also it works like vitamin A. They help to stimulate the synthesis of the junctions between the epithelium. So it's good for leaky gut syndrome, very good. Same like carotenoids. And also it helps for the healing of the wounds and ulcers because you need that epithelialization, and the BP 157 does that. So it does help to regulate the interleukin 22, which is responsible for that the epithelialization of the gut and even for the skin. So I will use that along with thymosin beta. So I would not use it in combination because then you are antagonizing the effect unless you have somebody who's healthy and you give them, so you don't want any polarization in the immune system. So possibly you combine, but most of the case I use it based on what's the purpose of using it, not just doing it just randomly like this. But in case if you have Lyme disease and you say I'm going to use thymosin alpha to destroy the Lyme, okay, but when you destroy it and you produce inflammation, too much of inflammation, then you say, oh, I want to switch it to thymosin beta so I can decrease inflammation. So that's what justify Dr. Bill of doing thymosin alpha for 1 month and then do thymosin beta to decrease inflammation that is being generated from the destruction of the Lyme disease. So that's something you may consider it. But very important to know exactly what you're doing. If it takes that, you need to do CBC differential to know your polarization of your immune system, which direction it is, in addition to cytokine profile. That would be great, so that you will not be shooting in the dark, knowing exactly what's the purpose of doing it. For the question of Dr. Patel for CD4, CD8, both thymosins help to enhance and balance the immune system, the CD4, CD8. So those does boost them and balance them. But the thymosin alpha tend to polarize the immune system to Th1, and also it helps to inhibit the Th17 in a way. It regulates it. So if it's high, it brings it down. And if it's low, it brings it up. So it balances the Th17. Thymosin beta,
Which one do you use, Dr. Halasa?
For what?
For CD4, CD8 ratio is high, means that CD4
So it depends
count
on the
is high
disease. So
and
what
CD8
are you
is low.
treating?
Huh?
So that's the reason you asked me that one time in the text. I asked you, you need to know the condition. If you do treating cancer, I need CD8 high all the time, and thymosin alpha will boost both CD4 and CD8, but it will more into CD8. You got my point?
Yeah.
So thymosins, they help to boost the immune system, both CD4, CD8, either beta or alpha, but they're different in polarization. One polarization Th1, which is thymosin alpha, the B and the thymosin B4 and BPC 157, it tends to polarize the immune system to Th2 Tregs, which are, so if you have somebody has asthma, you never give them a thymosin beta. If you give them Peptide, you can kill the patient sometimes because it will increase the interleukin 4 and it's not good for those patients. But what I will give for asthma, I'll definitely give them thymosin alpha.
Haven't killed anybody yet with the peptides.
What is that?
Haven't killed anybody yet with peptides.
Well, again, I think Dr. Patel has an experience when she put too much of thymosin beta. She see patients have wheals like allergies or itching, right? One case you told me about it, Dr. Patel. Do you remember when you say
Right,
like,
because she had really the Lyme autoimmune encephalopathy.
right?
Okay, so that would be TB4 would be the one that you would use. But she started having the anxiety kind of episode and she became restless. And so
Right. So let me get this. This is very important. So you have encephalitis and Lyme. So there's two portions that you have problem here. You have the infection itself. You need thymosin alpha for it. But then you have the inflammation of the encephalitis and you need the thymosin beta for it.
right.
So that's why you say, I'm going to use the same protocol of Dr. Bill. I will start with thymosin alpha, destroy the Lyme disease, and then I'll do thymosin beta.
I understand that for killing any organisms, along with the antibiotic, you use TA1, but but when they have a more neurological symptoms, you may want to go to TB4. But I think that I realized that the dose I gave was high. So all what I had to do was to start low and then gradually make it high. So, I think each patient does give you some sense that for that particular patient, you may have to go low. And some patients can tolerate the average dose and some patients need the higher dose.
Right. And so when you see any skin whales and all that, that's me you have too much of interleukin-4. That's me it's too much of thymosin beta. So you need to lower the dose. So that's just the clinical manifestation, and all this gives you inputs to adjust your treatment, basically.
So
I think
if they have a itching, if they have a rash, if they have a hives, then you use, what do you use?
I will lower the dose of thymosin beta
No,
sometimes.
no, but if they are not on anything, then what
Yeah.
would you choose?
So I will do thymosin alpha, of course. That's what I do. The reason why they have rash, because they have too much of Th2, which leads to too much of interleukin-4, which stimulate the mast cells and histamine release. And so that's mean they have too much of Th2 overactivities. I will use thymosin alpha. That's why I'm using it for allergies.
Right. So when somebody has a high amount of CD8 and low amount of CD4, what would you do?
So again, what is that?
Again, this is not the case of tumor. This is the case of sometime it is the allergy and sometime it is chemical sensitivity, or sometimes it is the like chronic fatigue or hypothyroidism or adrenal insufficiency, whatever you want to call.
Well, it depends on the condition. If they have low CD4 and high CD8, and let's say they have allergies, well, that's
Right.
good for allergies. But I still continue to do thymosin alpha for allergies, because and thymosin alpha will increase the CD4 and the CD8, but it will be more to CD8. But that's fine. That's what I need for asthma. You got my point. So it's all about the condition that you're treating.
So, okay, so that's what I'm doing, but you just wonder that sometime their CD4, CD8 count is 5.56 or 5.7. You just wonder now if you're using, you do increase the count, but after a month or two, you're still not able to balance. Where would you go?
Well, I need to find out why they have low CD4. They may have HIV. So thymosin alpha does both thymosin alpha and beta help to increase the absolute number of CD4 and CD8. So both are immune boosters.
Right.
But one tends to be moving to more to CD8, which is thymosin alpha. The other one moves it more to CD4 because of the Th2 thing. But if there's a problem still with using thymosin's medication, then I need to look at what's going on and why they have low CD4. It could be many reasons. One of them HIV. One of them could be other reasons that we need to figure it out. And maybe they have some myelodysplastic conditions, but really their immune system is not well balanced, and then we need to figure out the reason why. So it's all about the conditions and about the testing you're doing.
So then I thought that maybe Dr. Bell's protocol of 1 month using the TA1, 1 month using TB4, and that may improve the ratio because it increases one and decreases the other. So
yes, in case it's not cancer, I would do that. But in case of cancer, I will keep that.
Yeah. Then another question I have is this, like in a rheumatoid arthritis, it's Th17 dominant disease. So if it is Th17 dominant disease, then
okay, so the Th17 dominant disease and rheumatoid arthritis is both Th1 and Th17. Both are involved. Even multiple sclerosis, we find in both. And And in this case, I will use thymosin beta 4 to switch the whole thing, because thymosin beta 4 will inhibit the TH17 as well, and have the TH1 and TH1. So it will balance the TH17 and have the TH1. So I will do thymosin beta 4, and I will use the also use the BP 157, BBC 157.
Yeah.
I will use all the time BB 157 with thymosin beta. They are cousins, and BBC 157 will add more to the healing. So I would all the time use them together. I think that's what Dr. Bill is doing too, right?
So, Dr. Bell, have you used any of these peptides in autistic kids?
Oh, yeah, absolutely. So
Okay, what do you use in them?
We use, again, it is individualized because, you know, I'm the hormone guy. So we measure all of their hormones and we try to balance them. Frequently, what we'll find is an excess in androgens. So we'll want to temper them or damp them down.
What age group are you talking about?
Usually by the time they're in the 9 to 11 to 12 age group.
Okay, 9 to 12. Okay.
9 to 12. Early on, you'll find that they have an imbalance between growth hormone and IGF-1, and that's usually an inflammatory type situation. So we would use our thymosa alpha 1 there. We use very low doses there. We'll use the we'll get a liquid form made, and we'll use the equivalent of about 0.1 milligram 3 times a week. You make it into a dropper. Again, that's about. I don't do it for anybody younger than 6, as far as you know, these immune peptides. But you can get anti-inflammatory, antioxidant supplements that are very they're pretty effective. But you need to figure out, you know, where the imbalances are. You know, if you asked about autistic kids, do you deal with them at all?
Yes, I deal with them, and
okay. You know the saying, if you met one autistic kid, you met one autistic kid. You know, they're not the same, and I don't like I don't like putting anyone in a category saying, okay, you're autistic, you need to take this. You know, here's our protocol. We're going to give you these 6 things. I don't do that, because I really find that you really need to tailor it to each one. I have a protocol. If you guys want to hear, you know, I have some lectures on autism that I've done. You know, I have a protocol that we follow as far as diagnosing, and then we really need to break it down for each kid, and make it individual. In general, what we see is in the older kids, in ages 7 to 8 and up, they have they have an excess of testosterone versus you know, where they should be in their growth and maturation. Early on, you know, as you can pick it up, is if you know what to look for, and as early as 3 to 5 months, you'll find that they have a growth hormone mismatch. And by that I mean they'll have an elevated growth hormone, but they'll have diminished IGF-1. And so it took me a long time to figure out how could that happen. There's an outfit in New York City that treats these kids with IGF-1, which would seem to me that you would be throwing gasoline on a fire, but they actually do improve somewhat. So it's a cytokine problem. It's an inflammatory issue, and then so our job is to you know, block the offending cytokines, so that the IGF-1 you know, can rise to the level that it should. Okay, I don't know if that helps. We use a lot of low dose naltrexone for these kids. I don't know if you're familiar with that.
Yes.
And we use I don't use a whole lot of peptides with them, basically because you know, we live in the land of something goes wrong with one of these kids, and it's your fault because you did something that's totally outlandish. So I'm trying to be a little bit careful of that, and as I mature, I get more careful as time goes on. But there are a great number of anti-inflammatory, antioxidant substances or supplements that work quite nicely. We also have a whole stable of pharmaceuticals, drugs that we use in low dose off-label. And for example, we were talking about your patient that had rashes and inflammatory or allergy type symptoms. Verapamil, which is a calcium channel blocker, used for coronary disease and hypertension in low dose, has, and the dose is 10 to 40 milligrams, has anti-inflammatory and cytokine blocking properties. So, about a third of my lecture, the people that I lecture to are, quote unquote, white bread doctors, nobody here. By that I mean is, they'll only go by the book. They would never, recommend glutathione for somebody, or they would never recommend, it's like Thymolphysin beta 4 for, forget about it. But if I tell them, okay, let's use verapamil, 10 milligrams, and so what you'll get is you'll get your anti-inflammatory and your anti-allergy properties from there. So, when you do this kind of work, those are the kinds of things that you come across. That's a whole nother lecture. So we have some lectures on autism, and then I've also come up with some that I call sort of, what I've learned in anti-aging medicine for 40 years. We talk about off-label, repurposed drugs. And we also have some lectures on I don't know if anybody's heard our talk on the post-finasteride syndrome. Finasteride is used for prostate enlargement and for hair loss, and it opened up a whole can of worms. I thought it would be something that was simple. It took me 6 months to sort of sort it out. It was like sort of peeling an onion. And from there, we're good with other cerebral issues pop up. And I was almost let the cat out of the bag. But if you come Tuesday night to our lecture, and there's the Zoom link there at 5 o'clock Pacific, 8 o'clock Eastern, here's our commercial. I'm going to be presenting a case that looked like one thing and turned into quite an interesting puzzle. I'll give you this. It was a 39-year-old woman. I was the 9th doctor she saw in 3 years, and she had been perfectly fine. And about 3 years, she developed hallucinations, brain fog, fatigue, chronic fatigue, muscle wasting, and she went from being a vice president of a accounting firm to she's totally disabled and can't do anything. So I'm going to present that case because it's really quite fascinating. It was something that I had not even heard of, and I stumbled on the answer quite by accident. So I don't want to let the cat out of the bag. But if Dr. Lassa wants me to come back to talk about it, and Dr. Crowley,
of course, I want you to come back all the time.
Dr. Crowley, if you're
we're the same team.
Yeah, Dr. Crowley is supposed to present a case also on Tuesday night also, and so it's only going to take about a half hour, but I don't want to let the cat out of the bag. And Dr. Ortel says there's no accidents. Let's just put it this way. I was filling out a requisition form and I checked the wrong thing by accident and came up with the answer.
Yeah, there are some surreptitious way that it happens.
Well, let me add something here. So very important that the modern medicine is a little different from the old. We make sure that we are adapting those medicine. Now today, chronic diseases to know whether it's Th2 dominant, also Th17 dominant. So it could be Th1, Th17, it could be Th2, Th17. That's most of the cases. But you will never see two Th1 dominant. Okay, you will see Th1, Th17 dominant, and that's what is autism. Autism, it's Th1, Th17 dominant with the autistic cases. They are Th1, Th17. It would be good if you confirm that doing cytokine profile, CBC differential, but most of the cases they are Th1, Th17. The way we manage it is to shift them away from Th1, Th17 using thymosin beta and using the BPC 157. I think this is two things that you may be considered, along with other growth factors that Dr. Bill is talking about. But those are a thing that I will do with patients with autism, and then I will follow up with their cytokine profile. So it used to be old school, just give them antioxidant and give them glutathione, maybe an AD and all that stuff to decrease inflammation in the brain and the neuro, because there's some neurogliosis in autistic patients, and that leads to neuroplastic changes, abnormal neuroplastic changes of their brain. So in order to really restore the neuroplasticity of the autistic patients, then you need to manage the gliosis and the inflammatory process in their brain. So that's what I'm trying to say here, that don't shoot in the dark. Make sure that you are able to check the cytokine profile, the WBC differential, and then based on that, knowing whether it's Th1, Th17, Th2 dominant disease, and then you can manage it more effectively using the tools that Dr. Bill William just discussed. I think it's a great night tonight. I'm still on vacation in my cottage here, having fun with my family and the beach. But after this, I'm going to get my fishing pools and head to the beach and do some fishing there. But let's go ahead and thank Dr. Bill for his presentation. Wonderful presentation today. And then we're going to have Mr. Ken to talk about his endothelial function test. The other thing is that in order to monitor the efficacy of integrative therapies, it would be nice to manage to monitor to check the endothelial function autonomic nervous system, including autistic patients. They will have sympathetic overactivities, and most of the time you will get them abnormal endothelial function tests, although they're kids, but at least you will see some sympathetic overactivities there. It would be good if you start measuring that, and then you start doing all this integrative approach, including the antioxidants and immune modulators that we are doing here. So, Mr. Ken, are you there?
Yes, I am.
Go ahead, share your
Hi,
slides.
everyone.
The mic is yours.
Great presentation, Dr. Clearfield. So I'm just trying to share my screen.
All right, I shut mine off. Okay, there you go.
Okay.
It's all yours.
Oh, thank you. Let's see. And here we go. Let's see if I know how to do this. It should let me now. Got it. Got it. Okay, and we're Pulse for Pulse, and we do diagnostic testing and practices with zero out of pocket for the practice. We're not looking for any staff